Well, good morning again. Are we ready to get started? Okay, great. Did everybody get their booklet and their program book? Okay. So for time's sake, I am going to give you an abbreviated version of the bio of our wonderful speaker today. We have Dr. Van Bosse. I know, probably not the best pronunciation, but Dr. BB, as most people will call him. Very much dedicated to the field. He is a practicing pediatric orthopedic surgery professional who is completed his orthopedic residency, University of Illinois. And there's a wonderful bio here. I know you don't want to hear me talk, you want to hear him talk. He has treated many of the kiddos that we see here, many who are now adults as well. He's a wealth of knowledge, a wonderful man, a dad of 2 kids, wonderful spouse, and you will find him in the hallways making time for everybody and anybody who wants to speak with him. He's currently in Missouri, his new practice, so please feel free to reach out to Dr. Van Bosse, whether today, in the hallways, or later on, with any questions, expertise, referrals that you may need. He is always more than welcome to help all of you. So without further ado, Dr. BB.
Thanks, Maria. So anyway, I'm really lucky we're a little behind schedule, but they charitably put me right before lunch break. So I'm just going to keep on going through. Anybody who's got to run off to lunch, I don't feel rude. I won't feel that you're rude if you're leaving. I'm just going to go through. I'm not going to take questions during the talk, but I'm definitely available anytime after the talk or anytime you can track me down. But let's get going. So we can't really do a talk about arthrogryposis without talking about this painting, which hangs in France in the Louvre. It's about the size of a sheet of notebook paper. It was called the club foot, but if you take a close look at it, you see the hand shape is kind of like that, what we've seen a lot of our friends with arthrogryposis. And same with the feet. There's very much a club foot appearing arthrogrypotic foot there. So we think that's one of the first historical documentations of somebody with arthrogryposis. Now in the literature, it was first really discussed about 150 years ago, or a little bit more than that, by Adolf Otto here. And if we think that we have problems with labeling people these days, he titled his article, "A Human Monster with Inwardly Curved Extremities." Now, we've come a long way since that time. And this is more what our kids look like. And one of the important things that we always like to say is, the children look worst at birth, and then they unwind somewhat, and they keep looking better, which is always a helpful thing to tell new parents of a child with arthrogryposis. One of the common things that the parents are told is, we don't think your child is going to walk. And to a certain extent, I can understand that, but how do they know that this child here doesn't turn to that child there? Or this one turn to that one? Or that one turn to that one? So there's a lot of potential here that oftentimes the first people who talk to parents don't understand. And they haven't met so many people with arthrogryposis, so that's understandable, but all the same, we really have to be able to give people a clearer picture. So then we look to outcome studies, and these are really interesting. It says that ambulatory rates, people able to walk as adults, is somewhere between about 50 and almost 90%, depending upon what article we're reading. A lot of people choose to use wheelchairs in community and walk around the house, but they're still able to do walking. About the same amount are able to drive. Fully independent is less than that. It's only up to about a third to a half. And that has more usually to do with the use of the arms. That means that they still need some help around the house. Although we have some very inspired people who have been able to even tackle that with limited use of their arms. The majority have had orthopedic procedures. On average, someplace between 7 to 10 procedures, with some even rating up to about 70 procedures. And a lot will not complain of, but will acknowledge that they do have daily pain in oftentimes their feet and their ankles, in their knees, spine, jaw, and in their arms. And these are things that are very important for we who treat the younger patients with arthrogryposis to understand how to prevent that in the adults. And that's why these AMC registries that Ani was talking about with Noemi Dehan-Ulio, that's why they're so important. And also Vani Sarwatsky, understanding how we can do better to make quality of life better in the long run. So what is arthrogryposis multiplex congenital? Arthrogryposis means curved joint, with arthro is joint and gryposis is curved. Multiplex just means multiple joints. And congenital means that this is present at birth. And we shorten it down, just call it AMC. And the definition of this is a congenital, which means you're born with it, non-progressive limitation of two or more body parts, meaning that typically the contractures that somebody is born with are not going to get worse over time unless they're not using the joint. Then sometimes things do get tightened up. But by and large, what we see is what we get, and we have to just kind of work with that and try to make it better. There was an international article that, again, Noemi helped spearhead, that a number of us were involved with, where we tried to actually flesh out that description. If anybody wants a more significant description of that, they can look at that article. But in short, again, a baby born with multiple contractures, this is a sign and not a diagnosis of itself. And what I mean by that is that the term itself is kind of describing what we see. And my favorite way to put that is similar to saying, oh, I've got a cold. Well, what does a cold mean? Well, it means you're coughing, you're sneezing, you got a runny nose, you may have a sore throat. All those are the things that we can all relate to, but none of that tells us what caused it in the first place. Is it a virus? Is it a bacteria? Is it just bad allergies? Is it the wildfires from Canada? Sorry. But so it's those kinds of things that are similar to arthrogryposis, that the name does not really give us a definition. Overall, the incidence is about 1 in 3,000 births, but there are about 400 different things that cause somebody to be born with arthrogryposis. Some are much more common than others. So what do they all have in common? How can you have 400 different things that lead to somebody born with contractions? What they all have in common is that the baby is not moving much during pregnancy. This is called fetal akinesia. And if we look at it quickly at the stages of pregnancy, we kind of group pregnancy into two parts. You got the first couple of months, which is the embryo stage, where you take a cell from mom and a cell from dad, you put them together, and you grow it up into this rice kernel size person. And then the next 7 months are the fetal stage, where you take that little being and you grow them up into somebody who's big enough to be living outside the womb. Things that go wrong in the embryologic stage are malformations, and those are people with shortened limbs or things along those lines. In the fetal stage, this is where the baby is put together correctly, but then things go wrong subsequently. And this is really what arthrogryposis is, that everybody with arthrogryposis was pretty much put together correctly if we look at the bones and the muscles, the nerves, and the joints. But what happens is something goes wrong as they're growing up, and the part that goes wrong is that they're not moving. So most of us, we look at the back of our hands, we feel the little wrinkles we have on our knuckles. Well, that came because intrauterally we were bending and straightening our fingers. And when you bend them, you're stretching the skin over that joint. And when you straighten it up, well, that skin kind of wrinkles up a little bit. And underneath the skin, what's happening is that the tendons are moving back and forth in their sheaths. They're kind of sliding back and forth. All the ligaments are getting stretched to the right tension, and the bone ends are getting shaped appropriately to each other. So if you're not moving a joint during pregnancy, then all those things are getting missed. And you also get some other interesting things that happen, where you get some interesting skin creases, and you also get these dimples here. The dimples actually mean that the skin got stuck to the underlying bone, and it wasn't moving. So what are the other possible things that can happen? Well, you can also have a baby who's not swallowing or breathing the amniotic fluid. So you can have some lung issues, you can have some digestive problems, they can have a small jaw because they're not chewing. The gut motility issues, again, because they're not processing that amniotic fluid. And sometimes you can also end up with something called polyhydramnios. There's too much amniotic fluid because it's not getting processed by the baby. You can also have a short umbilical cord. Typically, babies are actually kind of swimming around the womb, and that kind of stretches out the umbilical cord a little bit. So if they're not as mobile, then the umbilical cord can be on the short side. And then we sometimes get this thing called umbilical wrapping, where some of the patients that I have these kind of spiral shaped, I don't know if I can draw, oh, there we go, these spiral shaped grooves, and some of those can actually appear quite deep, but what happened is the umbilical cord got wrapped around a limb. It probably happens to all of us, but many of us can shake it off, and some people with arthrogryposis can't shake it off. And here's, in fact, there's an MRI where we see this baby with the umbilical cord coming down, wrapped around their leg there. So what causes fetal akinesia? Well, there's many different pathways to that and to arthrogryposis. And in some cases, there are actually kind of multiple causes where one cause leads into another. But we'll go through some of these a little bit. We're starting off the nervous system. So the nervous system is really the communication between, for our purposes, the brain and a muscle. So if you have an abnormality in that connection, the muscle's not going to move, the joint's not going to move. And so you start at the very top. There are some of the children born with arthrogryposis have brain malformations. Two things that we talk about are absence of the corpus callosum, that's a little bridge between the right and the left side of the brain, that may not have formed correctly. Or they can have something called perisylvian polymicrogyria, which I think is still something that people are trying to understand what it means. The brain on MRI looks a little smoother and flattened out compared to a typical brain that's got a lot more of these kind of caverns to it. But with that, the brain's not working as a typical brain would. Because of that, you're not getting the connection down to the muscle. We got spinal cord abnormalities. We're going to talk about amyoplasia in a bit to explain the spinal cord abnormalities. And you can even have the nerves going down the arm or down the leg having abnormalities that stop the muscles from moving appropriately. At the very, very end of that, where the nerve has to attach to the muscle, there's a little connection it has to make, and that connection is where a chemical jumps from the nerve to the muscle to get the muscle to move. And in some cases, that is also abnormal, and that particularly in something called Escobar syndrome, where that's an abnormality. We'll talk about that a little bit too. There are some congenital muscular conditions where the muscle itself is the part that's the problem in all this. And in that we have things called the distal arthrogryposes. We'll talk about that a little bit, as well as the congenital muscular dystrophies, which is another whole group of conditions where, in this case, the muscle's not moving well, wasn't moving well during pregnancy. And then there are the connective tissue disorders, and primary amongst those, what I was just talking about, is Escobar syndrome. This is where you get kind of a winging or a webbing of joints. So you have this kind of winging here, this webbing across the neck there, behind the knee, in the axilla, in the armpits. One of the things when I first started in arthrogryposis, I had a lot of mothers who had the sense of guilt that they had done something wrong, or it was something in terms of how they were put together that caused the baby to be born with this. This is really relatively uncommon. And it's really worth stressing that most cases of arthrogryposis happen for reasons that we don't completely understand. But just to go through these real quickly, one is the lack of intrauterine space. If the uterus doesn't grow or is somehow blocked to growing so the baby can't form correctly. Quick point about that is that only becomes an issue further down in pregnancy. So you can have several months where there's more than enough room, and then you get a little crowded as the baby gets bigger. And when we have children with those kinds of situations, they tend to be the ones with the milder contractures who can actually stretch out and, in a lot of cases, avoid surgery. But it could be things such as a bicornate uterus, which is what we see on the lower right there. It could be a uterus with a lot of fibroids, or it could be twins and multiple births. In some cases, there's also a little bit of cramping, a crowding of the space if there's not enough amniotic fluid, something called oligohydramnios. Again, these are all very uncommon conditions that can happen. Some of the things that we do worry about, though, are infections or medical conditions, which is why we all urge all women of childbearing age to get all their vaccinations. But rubella, rubeola can cause some forms of arthrogryposis. The Zika virus was a big concern a while ago. Luckily, it's less of a concern now, but that did lead to a wave of children being born with arthrogryposis. And then there's other things that could be maternal conditions that can lead to a child being born with arthrogryposis, including multiple sclerosis, diabetes. We talk about diabetes. It's not something we see a whole lot of, though. Myasthenia gravis and hyperthermia. Medications and drugs. have also been linked with arthrogryposis. Fetal alcohol syndrome is one of the things linked to it, other medications as well. And then vascular compromise. If something happened where the blood flow from the mother to the placenta has been cut off for different reasons, such as placental abnormalities or placenta previa. Those are some of the reasons also that have been linked with arthrogryposis. And then monozygotic twins. Dr. Hall's got that study going on looking at monozygotic twins, or actually disappearing twins, where the thought is that there are a couple of twins and one is absorbed and the other one has arthrogryposis. So there's a lot of research going into that as well. So how do we classify arthrogryposis? There's a number of different ways. When you're looking at such a huge category of people and trying to break them down into relatable groups, it can be very difficult to do. And for that reason, there's different classifications depending upon how you're looking at arthrogryposis. My favorite way is essentially 3 categories about of the same size. And the first one is just classic arthrogryposis, what we typically call amyoplasia. So this is a single condition. This is a non-genetic condition. Oops, hang on a second. Okay, so second group, distal arthrogryposis. In here, there's about 19 different conditions. We're going to talk about each of these classes in a second. And the third one, I like to call the everything else category. But talking about amyoplasia. So this is the most common form of arthrogryposis. It's thought to be about 1/3 of babies born with arthrogryposis. But in my clinical work, it's probably more than half of the kiddos I see that have arthrogryposis. But it's about 1 in 10,000 births. It's not inherited, it's sporadic, which means if a family has a child with amyoplasia, they have about as much chance of having another child with amyoplasia as any other family would. Usually the symmetric positioning, so that the arm contractures are about the same, the leg contractions are about the same from side to side. Sensation is normal, and so is intelligence, and these are very important things to know when treating a child like this, that they can feel pain and they can understand what's happening to them. And we have to, as treating physicians, we have to keep that in mind. Overall, they have decreased muscle mass. A lot of the muscle, the skeletal muscle, is replaced with, at surgery, it almost looks like muscle, except it's yellow and it's made out of fat. They also oftentimes will have these characteristics. This is not just amyoplasia, it's arthrogryposis in general, but a lot of kids with amyoplasia will have what's called a hemangioma, a red spot over their forehead, their nose, their chin, and this one's actually called a nevus flamus. And this gradually fades over time, but in the little kiddos, it's always interesting to see when they get upset, it kind of glows, it's a little headlight. They can have a small jaw, and that again comes because they weren't swallowing and breathing during their pregnancy. The girls can have hypertrophic labial folds, or hypoplasia means that their labial folds aren't as well developed, and that's because they weren't moving their legs as much, interestingly. And the boys can have hernias or cryptorchidism, where the testes haven't completely come down into the scrotums. In the arms, the typical thing, now there's typical and then there's, all different forms of that, but the typical finding is that the shoulders are adducted kind of to the inside. They're turned inwards. The elbows are usually straight, although we have a number of people where the elbows are born bent. And then the wrists are bent, and the fingers are kind of bent and off to the side. That's a typical find that we have. In the legs, they tend to be, the hips are flexed up, they're turned outwards, and they're also kind of opened out. And we call that kind of the Buddha position. And about someplace in the neighborhood of 1 out of 4, 1 out of 5 have dislocated hips. The knees are most commonly flexed, but sometimes we'll have kiddos who actually are born with their knees extended, and we have to work on trying to get them to bend better. In amyoplasia, by and far, the foot deformity that they have is club foot deformity. There's another foot deformity, we'll talk about that in a little bit, but we don't find that one very much in the kids with amyoplasia. It's really just the club feet that we find. So we don't really know what causes amyoplasia, but like we said, as far as we know, it's not genetic. We're still doing a lot of work looking into that. The thought is that it is probably some kind of an interruption of blood supply to the baby at a critical point. And just at a point where you're developing something called the anterior horn cell. So we're going to give you a quick little anatomy lesson here. Here we got a spinal column here, and if you take a section out of that and you look at it, this is what the spinal cord looks like when you're cutting through it. And then you have, this is the front, we call that anterior, here's the back is posterior. White matter here, this is actually the nerves going up and down, and on the inside you have what's called the gray matter, and that is actually where nerves come together. So the nerves come from your brain, meet the nerves going out to the muscle in those areas there. So you got a path going down from the brain through the column up to whatever level that nerve is going to exit, and it has kind of its receiving end of the synapse. And then you got the nerve that goes down to the muscle that exits out there and goes off to the arm or the leg. And this is the rest of the synapse. This part right here is the cell body. That's kind of the hubbub, the main center of the nerve itself. And in this case, it's called an anterior horn cell. And what happens, what the thought is, what happens is that there is a interruption to the blood supply. Sorry, just trying to back up a second. There's an interruption to the blood supply just as these anterior cell bodies are developing, these anterior horn cells are developing, so that you interrupt the connection from the brain down to the nerve. And the question is, well, how come only certain people have arms involved, legs involved? And what we actually find is there's a certain pattern to that. So the most typical pattern is that arms and legs are both involved. You have a fewer amount where only the legs are involved, and an even smaller amount where only the arms are involved. A number of them do have scoliosis, though. So why do they look this way? Well, it has to do with timing. So it turns out that when we started moving in the womb, you first start at the head level, and then it goes all the way down, arms, and then down to feet. You actually move your right side before you move your left side. So if something happens, if there's a pinpoint insult to the blood flow to the baby at, say, 8 weeks, only the jaw is involved. If it happens only at 9 weeks, then it's going to be the arms that are involved. If it happens at 10 weeks, you've got some arm involvement, some leg involvement. If it happens at 11 weeks, it's only the legs that are involved. Now, what about if you have something severe that happens early on and it continues to be an issue throughout this critical period? Well, then everything's going to be involved. That kind of gives you an idea of what that landscape looks like. Now, switch now over to the distal arthrogryposes. This is a group of, there's about 19 different distal arthrogryposes, only about 11 of them have been named. But these are autosomal dominant conditions, which means that you only need one parent to have the condition to pass it on. And in fact, if that one parent has the condition, roughly half the children that they have are going to have the condition, or on average, half the children will get the condition. Many of these are what are called de novo mutations, though. That means that the child that we see is the first one in the family to have that. Neither one of the parents actually had the condition. It also has what's called reduced penetrance and variable expressivity, which is a very nice fancy way of saying that the parents, if a parent has the condition and they pass it on to their child, that there may be a real difference in how severe one person looks compared to the other, how severe the parent looks compared to the child. That the child may be less or more involved than the parent is. And the most common forms of the distal arthrogryposes have actually something to do with what's called the fast twitch muscle proteins. So I'm going to take you through a little bit more anatomy here for a second. So when you're looking at an arm, your big muscles, the ones around the shoulders, these are slow twitch muscles because they're powerful muscles and you don't have to move them really fast. In your hands, these are the fast twitch muscles. These are the ones that have dexterity. This is why we can type so well on our telephones. And those are actually two separate looking type muscles if you look at them under a microscope. And what happens is that some of the muscle proteins that make up your fast twitch muscles can be vulnerable to genetic abnormalities. So here's a quick little fast twitch muscle here. So this is actin. These little beads are the actin beads. And then over them is this green band, which is the troponin, the tropomyosin. and the tropomyosin has a little troponin switch on it. At the bottom here, we got myosin. So the way that your muscle moves, if this is the myosin, this is the actin, is that the myosin kind of inchworms its way up. That's how, and you got to think about this. Every time I'm doing this is happening thousands, if not millions of times in the span of a second. That little maneuver over there just blows my mind. But each one of these little subunits here, whoops, that went wrong. Each one of these little subunits here can be affected by a mutation. So the actin chain can be abnormal in some forms of dysarthrophosis, or the tropomyosin can be involved, or troponin. And then there's also a number of different things where myosin is involved. So if we look at it here, here's the 11 named forms of dysarthrophosis. There used to be this thought that there'd be one gene cause one condition. If we had something wrong with the myosin heavy chain, that was only going to lead to dysarthrophosis type 2A, for example. That's completely been thrown out the window, because what we found is here we have these 4 different types of dysarthrophosis, and each one of them can have a myosin heavy chain abnormality. Now, those are probably different kinds of mutations within that myosin heavy chain, but it can cause 4 different things that we call dysarthrophosis of different types. Here's another 2 that have to do with the piezo-2 gene. Here are some tropomyosin and troponin genes that are abnormal. So you can see it's more than one gene that can cause one condition, and one condition can be caused by more than one different gene, which has kind of led us to think that the dysarthrophosis are more really a spectrum than discrete conditions. But just to run through a few of them, they have oftentimes a very characteristic way of appearing. If we look at what we call the classic distal arthrogryposis, the type 1, which is not the most common form, but they'll have fingers that kind of overlap, and the thumb is oftentimes a thumb and palm deformity. They can either have club feet or they can have the other thing called the congenital vertical talus, and we're going to talk about those a bit more later on in the talk. One of the more common forms of dysarthrophosis was called Friedman-Sheldon syndrome. This is type 2A, so DA dysarthrophosis 2A. And this, we were all taught in medical school, is called whistling facies. They have a small mouth opening. They can't open up very wide, and it kind of looks like they're puckering to whistle. They have some facial involvement. They can either have club feet or congenital vertical tali. And then there's another form called Sheldon-Hall. For the longest time, it was thought that kids with Sheldon-Hall actually belonged in the Friedman-Sheldon group. And then they started saying, well, no, there are differences. Friedman-Sheldon has a lot more scoliosis than the Sheldon-Hall kids do. The Sheldon-Hall kids have less facial involvement. And they're also, from my perspective, their club feet are not as bad in Sheldon-Hall than they are in Friedman-Sheldon. And then something completely different, something called Beal syndrome. These are actually tall kiddos with long arms and long legs. They look very much like people with Marfan syndrome. We think that maybe President Lincoln had Marfan syndrome. He was tall, he had long arms and long legs. The difference is that children with Beal syndrome, or people with Beal syndrome, have hand contractures, whereas your typical person with Marfan syndrome does not have hand contractures. And that's kind of how you differentiate them. And then this is the third category in arthrogryposis. This is the everything else. And this includes a number of different things. And among those, before we get to this, I have to actually mention that it involves, oh, I know, Josh. So I just got the 5-minute warning. And what I said at the beginning of the talk, Josh, is I'm just going to keep on going until lunchtime. So anybody who wants to leave can, and I'm just going to keep on going. But so there's a number of kids with arthrogryposis who do not survive pregnancy or do not survive their first year. And among those are some of the lethal conditions. And there's several of those. Then the thought is that up to a third of people, of babies with arthrogryposis did not survive. And it's a very sad thing that we grapple with. And that's a number of those are just some of the genetic conditions. So, we're not going to talk about that anymore. We're just going to talk now about those who do well, which is, for example, here kids with trigium conditions, which you also think of as Escobar. We talked about the winging and the webbing across the joints. And there's many different appearances here, but there's really just two different kinds of genetic conditions that lead into them. We group them together and call them Escobar syndrome. The most common form of Escobar syndrome, actually, when we're talking about the nerve going into the muscle and the little communication there, the most common form of Escobar syndrome is where on the muscle side of that communication, the receiving end, the receiver, is not built correctly. There's a gene mutation in that receiver. Now, and I didn't make this point with the distal arthrogryposes, and I should have, the gene that we say is abnormal actually gets replaced by another gene right before the kids are born. If you look at the proteins in the muscles of kids with distal arthrogryposes, or you look at the proteins that make up the receiving end in kids with Escobar syndrome, those look very normal under the microscope, and that's because they now have a normal gene there. But it's that gene that was working during pregnancy that caused all the problems. It's no longer active, but we're left with the results of that. So some more pictures of people with Escobar syndrome. And like I said, so it's the mutation of the acetylcholine receptor that we have the problem. And again, it is something that is replaced before they are born. Now, this is similar to a certain extent to myasthenia gravis. Myasthenia gravis, it's an adult condition where actually the acetylcholine receptor is not sensitive to acetylcholine. Acetylcholine is a little messenger that jumps from the nerve to the muscle, and so the acetylcholine receptor is the part on the muscle side that receives that message. And so if there's a problem with that receiver, you're not getting the message across. In myasthenia gravis, there are medicines that help with that, but unfortunately, it doesn't work as well in people with Escobar syndrome, because like we said, their acetylcholine receptor is now well made, is functioning appropriately. It's just that there's been some other damage that's already occurred. So let's get into treatment here. First of all, treatment, it's obvious to everybody here, it's a team approach. It takes the family, it takes geneticists and orthopedists and physical and occupational therapists and a whole group of other people. Treatment can be physical therapy, it could be splinting and bracing, casting, it can be surgery that includes releasing soft tissues or doing soft tissue work. Soft tissues means muscles and ligaments and tendons, or it could be operations on bone. So we'll go through a few of these. The main goal as a pediatric orthopedic surgeon who specializes in spine and in legs, the main goal for me is to get kids up walking. But it's also very important for me to realize that that may not always be the main intent of my patient, and that there are some kiddos that we really need to work on is their ability to be independent in using their arms. And so it's always the thing we have to keep in mind here. So important facts, children with arthroporosis by and large are very intelligent. They are sensitive to pain. We cannot restore an abnormal joint. So if you have a joint that was born abnormal, we cannot make it normal. We can just try our best to maximize what it can do. And there's definitely a spectrum to arthrogryposis. It's nice to have an accurate diagnosis of what underlies the arthrogryposis, but it is not always possible. We're getting better and better with genetic testing. It's becoming less and less expensive, but even with that, there are gray areas. So usually, from my perspective, I want to treat what I see and keep hoping that we can get a diagnosis to be able to refine what we're doing, but I don't need to wait for the diagnosis before I start treatment. And also, children learn to compensate, and that can work two ways. We have a lot of children who have learned how to work with their contractures and be able to function with them. But that's not to say that we need to, if they've learned how to compensate, that we leave them as is, because that also means that if we make something better, they're going to learn how to work with that. My favorite story with that is when I first started arthrogryposis. If you had a child who used two hands to write, people said, well, this is great. We should leave them alone because they figured out how to write. Well, really, if that's true, then if we can take their hand and put into a better position for writing, now they can write with one hand. And that was a kind of a lesson for us all to learn. So there's no single best answer. A lot of this, as a group of physicians, we're all working through this together. So what I'm going to talk about now are pretty much my opinions. and a lot of that changes with experience. And my favorite Will Rogers quote is, "Good judgment comes from experience. A lot of that comes from bad judgment." And treatment needs to be individualized. So I'm going to talk about my algorithms for treatment, but also we look at the patient that we have and try to figure out what works best for them. So for me, by and large, I like to treat the feet as a young baby. It doesn't have to be an absolute newborn, but that's one of the first things I'm going to start treating, is trying to get the feet somewhat straightened out. The hips, someplace between 12 and 18 months, I'm going to address it, but for most things, there's not really an upper limit. There's plenty of children that we've worked on that are much, much older than that. And the knees, most of the knee things, probably about 4 years of age, so we start to address them, just so that we have a child with larger anatomy that's easier to work with, and also we have a child that could be more compliant with physical therapy. So start talking about the feet. So the feet kind of come in two varieties. We have the club foot that's on top, and the congenital vertical talus is what those two photos on the bottom are. Start with the club foot. This is by and far the most common foot deformity we find in arthrogryposis. And what we're trying to do with treatment is get a foot that's nice and flat to the ground, that we can brace well during childhood, and that we try to get through childhood with the least chance of recurrence. One of the important things to know about arthrogryposis club feet is that most of them relapse. Sometimes it's just one relapse during childhood, we're really lucky with that child, or it can be other ones that we are doing repeated casting. Over time, the relapses take longer to happen, so we get more and more time between castings. And at some point, the foot kind of gels out. It holds its position, and then we're good. And oftentimes, what we're really hoping for is that the foot ends up in a nice flat-to-the-ground position, that if the knees and hips are moving well, then the adult does not need any kind of brace to be able to walk, because the foot's in a nice position. So we try to do things with as little surgery as possible, and we already talked about the relapses. And what we by and large do is the Ponseti casting. So Ponseti casting was first described for what's called idiopathic club feet. These are club feet not related to any other condition going on. And so it'd be a matter of casting them. So this is just a group of models done of casts. Now this is the first cast they put on of a left-footed club foot, second, third, and here's at the very end. And then here's a couple of pictures of actually putting on those casts. And what we found is that we could do this well for kids with arthrogryposis, even though it was first described for kids with idiopathic club feet. We had to make a few changes, though. One was that occasionally had to do what's called the Achilles tenotomy early on in the treatment, instead of waiting until we finished up all the casts. And we also needed a different brace. So we'll talk about that a little bit here. So the one procedure that just about every club foot needs is something called an Achilles tenotomy. And typically we try to do this as what's called percutaneous Achilles tenotomy. It means you take a scalpel, and it sounds a little gross, we just make a little stab incision right in front of the Achilles tendon and turn our scalpel to the side and nick through the Achilles tendon. So we're cutting straight through the Achilles tendon. It heals up over 3 weeks' time in the cast. But this is something that typically can be done as an office procedure in the young kids. We put some numbing medicine on the back of their ankle, we inject a little bit of local anesthetic, and we can do it this way rather than taking it to the operating room and hitting them with hard general anesthetics. So here's a picture of one of my patients. He's got severe equinus, meaning that the foot is really severely down. The Achilles is very tight, and that stopped us from being able to start our casting. So we're injecting a little local anesthetic there. There's making the little nick. And here actually that's our whole incision there. So you loosen up the Achilles tendon. And here's this child in the first cast. So you can see how much of a correction we get just from that first cast. In this kiddo, we had to nick the Achilles first. But then we can take feet that look like the ones on the left here and turn them into ones that look on the right. The bracing, so the braces that I have shown here are the typical ones for kids who have idiopathic club feet. And they work really well. It's a couple of shoes with a bar in between. If you have 2 club feet, you turn both feet out like that. And the way they work is that typical babies are kicking. And when they kick, they're stretching everything out themselves. They're doing a little bit of physical therapy on their own. The problem with arthrogrypotic kids is when we put them in these braces, they very quickly get their club feet back. And that's probably for a couple of reasons. One is that Most babies with arthrogryposis do not kick very much. And the other reason is that they also have hip and knee contractures, so that when you turn that foot out, you're not turning out nearly enough to get the stretch on the foot that you need. I'm actually going to talk about one other reason in a second here, but the brace that I like better is this kind of a brace. This is for an older child. We call it a leaf spring, meaning that the plastic and back is kind of thinned out, so it's got some flexibility to it. So during the day, they wear the brace like this, and at nighttime, we have some straps that can pull the foot up a little bit and stretch out the Achilles tendon. This is not perfect. We still got recurrences with us, but we're able to slow down the recurrences, and that's the important thing. So just a few more kiddos to show. This boy over here, 3 years old. When we first met him, he hadn't been treated before for his club feet, and you see those calluses there. That's actually because his club feet were so severe that when he walked, he was walking on the kind of the back side of the foot. So we did initial Achilles tenotomy, we did 9 casts, we did another tenotomy at the end of that, and that's what his feet ended up looking like. So we were able to get him up walking. He did have relapses, but we never lost the ability to keep him walking. Here's a 12-year-old boy when we first met him with a couple of severe club feet, and he actually had prior surgery. So there's the surgery right there. And actually, I should mention that the relapses happen regardless of the treatment that we do. So if we do surgery, if we do casting, we're going to get relapses. The difference is if you do casting, you haven't created any more scarring. The other thing is that if a doctor has a mindset of surgery for this, when they get a relapse, then they think, oh, I have to do more surgery. Well, I've already done my one surgery, loosening up all the soft tissues and make all the tendons longer. My next choice is now to start taking out pieces of bone. And again, that's what we want to avoid. But so with this young man, we did, I can't remember how many tests we did. It was about 3 months. They would travel from Tennessee to Philadelphia about once or twice a month. And we just cast him out, so we got him all the way straight, got his hips and knees lined up, and got him up walking with crutches. So relapses. Here's a 3-year-old girl from Haiti. This is what her feet looked like when we first met her. We were able to get him straightened up. We had to come back a few times more to do some more casting. This is what she looked like at 17. I think we had to do about 3 or 4 intervals of serial casting with her, but able to keep her feet otherwise corrected so she was able to get up and walk. This is what we want to avoid. This is a 15-year-old who came to my practice after having had a number of procedures. And when I look at these x-rays, I can't even name what bones are left over. And the only way to correct this was actually to make several cuts in the bone and slowly straighten it out with an external fixator. So this is what we want to stay away from. One more child, 9-year-old. Sorry, these are my, like showing kids, my kids' pictures. So 8 sets of casts, did Achilles tenotomy, did some more casting, and got her straightened out. But she makes a good point here. So you notice how these feet are now turning very far away from each other. They're very turned out. Because that's another thing we found with the kids with arthrogryposis. They have many of them, if they have arthrogryposis and club feet, they have an outward twist of their shin bones. So let me explain that a little bit. So here we see a couple of feet, and what those arrows are pointing to are your 2 little ankle bones, one on the inner side of the ankle, one on the outer side of the ankle, and you can draw an axis through them. And if you compare that to the axis of your knee, your ankle is turned out about 20 degrees compared to your knee, so that your foot, both of our feet should be turned out about 20 degrees. Now, children with arthrogryposis, we call that the intermalleolar angle, theirs are turned out sometimes 50 degrees, sometimes up to 90 degrees. So if you look at this girl here, the arrow is pointing at the ankle bone on the inside of her ankle. You can see how far forward that is. And the one on the outer side of her ankle is pretty much straight behind the ankle. Here's another child, though, and you can see those feet are pretty parallel, and the feet, a little bit of a club foot, but not bad at all. But now I have my fingers, again, on those malleoli, those little ankle bones. You can see in this child's case, the malleoli are turned out about 75 or 80 degrees. So what's the point with all this? Well, we have to be aware that there could be a twist in the shin bone. If we get the foot well corrected by casting and the foot's turning out a lot, we should untwist the shin bone to get the foot forward again. And usually I wait until the child's at least 4 before I do that. But that will slow down the recurrences because now we're able to keep the foot well corrected with the brace and yet have the feet pointing forward. Now, on the other hand, if we correct out the feet with casting and the foot is lining up pretty well with the knee, it doesn't matter how much twist is in the shin bone. That between the foot, the ankle, and the rest of the leg, everything is lining up. We just leave it as is. It makes a real messy x-ray, but what we care about is how everything lines up. But what about the ones that are twisted out, where the foot's turning way out, such as this one here? So what I'm showing you here is that this is an x-ray of the front of the knee, and yet the ankle's turned all the way out to the side. So there's a real significant twist in that leg. And if we're looking at the side view, well, there's that malleolus. Well, that we should be able to see that in the side view. It should be overlapping the bone, but that's how far turned it out it is. So what we do then is untwist the shin bone, like I'm showing in this x-ray over here. We'll make a little cut in the bone and just simply turn it out so the foot's pointing forward, put a little plate across that and let that heal up. And that seems to work well. And I said timing is very loose. I've done this in full-grown children, and I've done it in children as young as 4. Before that, we're really trying to figure out how everything is going to kind of settle out. Now, there's a variant of the club foot that we call the equino-cavus club foot, which is, it's got some subtle differences, but one of the big things we find is this crease that goes all the way across the foot. They don't have as much of the heel rolling in, or as much as what's called the adductus, where the front of the foot kind of turns inwards. But what's important about this is that we cast these a little bit differently than we would the typical club foot. So we need to recognize that this is a different foot shape and requires a different kind of casting so that we don't end up with a foot deformity that we've actually created by casting it wrong. And so again, you can turn that foot in the upper picture to the feet in the lower picture there. And once again, we use the same kind of bracing for them. Now, one of the things is that with these feet, you can see how these toes are very curled under. Oftentimes, that's our big issue. We get the foot well corrected, but the toes are curled under, and we have to keep on doing things to keep those toes straightened out. So you have to nick the tendon sometimes or the toes, and even occasionally put pins into the toes to hold them up. So that's just how we correct them, and a couple of feet there. All right, now, there is a common procedure called a talectomy that in the literature, in the medical journals, a lot of people advocate actually doing a talectomy very early on. What a talectomy means is taking out the main ankle bone, this one right there, and saying, well, if you take that out, now you can put the foot in the position you want it in, and it's going to look good. And coming out of the operating room, the foot usually does look very good because you're just creating a lot of space to be able to put that foot in the right position. The problem is that over time, you get a fusion between the shin bone and the heel bone, the tibia and the calcaneus. And this could be a very stiff deformity where the kids are way up on their toes, or they can, because we've taken out a bone that's on the inner side, the inner board of the foot, they can get a curve to the foot that's really very stiff that you cannot correct out. So oftentimes, doing a talectomy means that you're going to end up with a problem that just keeps on going on. So one quick thing. Mo, so it's lunchtime right now. Can I just go as long as people will be patient to listen to me, or do you need this room for something else? Huh? No, we're still talking because we started late. And 12:30. Okay, good. So we got 15 minutes for you. We're going to make this work. All right. So, in short, I do not like talectomies. Please do everything you can to not let your child have a talectomy. Congenital vertical talus, this is the other kind of clubfoot deformity. This is kind of the exact opposite of a clubfoot. And what happens here is that the foot is actually turned way out to the side, and somebody came up with a very nice way of casting the foot back over so you can get it pretty much straightened out, and all you're left with is a couple of bones in the front of the foot that don't line up. You have to do a small operation on the side of the foot to get those two bones, line them up, put a pin across them. Now, these do relapse also, and occasionally you have to do a secondary procedure down the road, but this is a much nicer way of treating it than the old way that we had where, again, you'll, like the clubfoot, open up the whole foot, lengthen everything out. So you can take feet that look like that and turn the feet like this, and this is just the scar that we have. That's all that we have to get the foot corrected. All right, now I'm going to move on to the hips. So there are two ways that we can have hip problems in arthrogryposis. Most common is just having a hip contracture. Oftentimes these are flexion contractures, which means that the hip is bent up. We can't straighten it out. And that we can actually treat through a very small incision just below, if you feel your own pelvis here, you got that big bump there. Right below there are where some tendons come off that become scarred down, and they stop the hip from getting stretched out. So through a very small incision, just like we did with the Achilles tendon, we can actually loosen up some tissue around the hip. And I'm not going to go through all the anatomy here, but so for example, here we got a child who's got a 30-degree hip flexion contracture. Make a little incision there, and that allows us then to stretch the hip out, so we get a fair amount of correction. Or this child here, who started off with a 115-degree flexion contracture, before we did some bony work on her, we just wanted to stretch her out a little bit. So we did that little release, and we got her down to 45 degrees, and that meant that what we had to do subsequently became much less involved. The more common contractions, though, are the ones that involve not just flexion and extension, but also the hip is way out to the side and is turned outwards. We call it multiplanar, so it's going across different planes. And so what we came up with that, so if this is the ball inside the joint for most of us, this is what it looks like for these kids with the contractures, and it's impossible to get that ball into the right position within the head. So instead what we do, to leave the ball where it wants to be in the head, we cut the bone here and we bring the leg down to where we want it to be. And we outline that here. So this is the girl on the left. This is what her x-ray looked like where she was just laying down. And so we made a little bone model. And what we do is we make a cut at the top of the bone. We make another cut below that, and we take out this wedge of bone. And when we take that out, we can collapse the bone down the direction we want it, untwist the bone, and then put the two pieces together so it looks like that. So we've really just brought the leg down to the position that we want it in, so the knee is where we want it to be. So again, this is where our bone model started. This is where our bone model ended up. We hold in place with this little question mark looking piece of metal here. And so we looked at a lot of the kids that we had done this on so we could publish this, just to give you an idea as to what all the results look like, and all the mathematics that go into it. But in essence, what we found is if our typical contracture, the kids with the hip bent up, off the side, and turned outwards, we're able to correct all those deformities pretty well. So that the kids with hip flexion contractures, on average, have hip flexion contractures about 50 degrees, and we could get them down to about 15 degrees. Or the ones that could not, their legs are so far out that they couldn't bring them inwards. On average, they were about 20 degrees short of the midline, and we could bring it so it was 20 degrees past the midline. And the same thing with rotation. So if they were stuck with the foot turned outwards, and we're trying to turn it inwards, after the procedure, we could turn it nearly or more than 30 degrees more in than it was before. The other thing is a concept called the total arc of motion. So this is how much range you have in your joint. So if we look at Black Panther over here, these are my kids' toys, so this is an easy thing to use. So Black Panther can straighten his hip all the way out. He can only bend it up to about 50 degrees, so his total arc of motion is 50 degrees. But what about the Black Panther's got a flexion contracture, so he's got a flexion contracture of 30 degrees, but he's able to flex up to 80 degrees. Well, here the total arc of motion is now also 50 degrees. So that's how much range he has in that axis of motion. So when we looked at the kiddos that we had here, and we looked at the total arc of motion, what we found is that preoperatively they had a total arc of motion about 74 degrees, and that actually got better over time to almost 90 degrees. So that was also very helpful for these kids. All right. That's Sophie, and there she is up standing. Or this child here, this is literally how this child's hips look. They were east and west. And we got them in line, and we got her up walking. So we put them in a Petrie cast. There's a Petrie cast, long leg cast on both legs with a bar in between the ankles. That's on for a total of 6 weeks. And then we looked at how our kiddos did, and none of the kids were walking before we operated on them. And at the follow-up that we had 29 kids who were walking independently, and some more that we expect over time would be getting up to walking independently. Now, the dislocated hips, okay, 5 minutes. Dislocated hips, real quickly, I'm just going to say that there's been a thought out in the general public, in the orthopedic general public, that kids with arthrogryposis with dislocated hips, you just leave them out. And that was based really on conjecture. There was an article back in the 60s that someone had written, just a paragraph on arthrogryposis, and their last line was, if 2 hips are out, you leave them out. If 1 hip is out, then you go ahead and put it in because you can balance the person, but nothing else. No data, no anything else. And everybody else has been saying that same line since. Although there's been a lot of research that other people have published saying, you know, I got my patient with arthrogryposis and I put the hips back in and they've done better. So what we actually did is we took our patients and we looked at them, but we looked at what the range of motion was of the hips before surgery and what it was after surgery. And just to go through it real quickly, first of all, the hips all have sockets. There's all a place to put the hip in place. But in essence, what we found, looking at that total arc of motion, the total arc of motion only changed 4 degrees, which is very, very minimal. But we were able to improve their function a lot. We get a lot more people up walking. I'm going to skip through this because I just want to hit the knees real quick. Sorry, I'm only going to run through here. Okay, so knee contractures. We're talking about the flexion contractions. That's the most common sort. And if we divide them into mild, which are the ones that have about a 25-degree contracture or so, to the ones that are moderate, that's 25 to 50 degrees, and the severe ones, there's 50 degrees or more of a contracture. So the mild or moderate ones, we like doing something we call the femoral anterior distal hemiepiphysiodesis. And epiphysiodesis is closing down the growth plate. A hemiepiphysiodesis is closing down one side of the growth plate, so the other side keeps on growing so that you can get a gradual correction of your deformity. So in this case here, what we're doing is we're tethering the front of the growth plate. We let the back of the growth plate keep on growing. So if this is the thigh bone, this is the shin bone, here's the knee. This is the growth plate. If we stop that growth plate from growing temporarily, but we let the back keep growing, then you get this. You kind of fake a straight knee. And then you can take these plates out. Now, what happens over time is that bone wants to go back to straight, and that's what we want to use bracing, is to make sure that when it goes back to straight, it's not doing this, but actually it's doing that. And all the soft tissues back here are stretching out. So this works well for contractures less than 40 degrees, and actually slowly been going up to contractures of 50 degrees or so. But here you can see kind of how this works. So if you look at the growth plate here in the beginning, it's pretty much perpendicular to the shaft, and then over time, it becomes a lot more oblique as the leg is kind of faking a straight knee, as I like to say. So this is that leg looking nice and straight now. The surgical technique, if it's a small contracture, 25 degrees, 30 degrees or less, we can actually do it through 2 small incisions that are about 3/4 of an inch big on the other side of the knee. If it's a more significant contracture, then we actually have to do bigger incisions on either side of the knee to loosen up the structures behind the knee to help that knee stretch out. Again, we looked at our patients. I'm just going to breeze through this and to say that we got a lot more flexion. Now, over time, as you get the remodeling, they do get tight again. They lose some of their improvement. And occasionally, in the kiddos, you have to do a second set of these plates 3-4 years down the road. We do lose a little bit of total arc of motion. It was about 10 degrees or so. So it is something that we lose a little bit of overall motion, and that usually is in the flexion range. But it does improve their walking substantially. And again, so it just shows you that a lot more kids were walking if we did this. I've now converted to a little bit of a different way of doing these, which my incisions are now directly on the sides of the knee instead of a little bit in the front of the knee, and that makes it just a lot more comfortable by and large because things aren't rubbing. Oh, I'm really getting the X. All right. Well, then we're just going to pretend like we didn't hear that. We'll just go real quickly through what we can do for the more severe contractures. So in little kids, in older kids, kids are almost done growing, if you have a very severe contracture, you can try to get a quick fix of that. Go to the operating room, make a cut through the bone right about here, and kind of the same idea as we just talked about, except now we're making a cut through the bone, and we're automatically straightening it out and putting some metal across to hold in place. So again, we faked a straight knee. Now that only works for certain size of deformities. If we try to do more than, say, a 45-degree contracture, so you end up with a very strange-looking bottom of the thigh bone. It doesn't work real well. But what about the kids who are still growing? Also, you can't do the young kids because they actually reshape their bones like we were talking about before, and the contracture will come back very quickly. So the more severe ones, this is the part where people always get very squeamish, we put on what's called an external fixator. We loosen up behind the knee, and we put this on. This is a frame where you got pins going through skin into bone, and we connect it to this frame, and the frame has hinges on the other side of the knee, and we have this telescoping bar here. And as we shorten that bar, it makes the knee gradually straighten out. Now, this looks very scary. The way that I can make this easier for parents to understand how survivable this is that most kids who need this have both knees involved. We don't do them simultaneously. We do one knee at a time because there's a lot to go through to do two. But I've never had anybody that after we first straighten out the first knee said, okay, let's go to the operating room. We're going to take off the frame. We're going to put that first leg into a cast and do the same operation on the other side. Nobody's ever said, no, stop right there. That was just too much for us to go through. In fact, they usually say, we're really excited because we've got this knee straight. We now see a chance for being able to do some good walking. We're looking forward to getting the other side done. It's not a walk in the park, but it is survivable, and that's the important thing. Again, we did research on this. I can't go through this right now, but happy to do it another time. And we're just going to finish up here with my friend. So here he is. He's actually upstanding in his KAFOs, but really hunched over. There he is with his fixators on. I always say this is either Halloween or he's really angry at me. And then we got him up walking. And my video is probably not going to run, but here he's up walking with short braces. And that is the end of my talk. So thanks very much, everybody. So I think we have to vacate the room, but I'll come out here into the lobby if anybody's got any questions for me.
Thank you.